Okay, here we are again, just like another haunting. But anyway, what we're going to do is we're going to start on the respiratory system. And today our focus is going to be, first of all, a little bit about what the respiratory system really does, because it's a lot more than just exchanging air and exchanging gases. But the majority of the time we'll be talking a little bit more about the anatomy that we have in regards to the respiratory system, so you understand that. So when we get to our next video, PowerPoint, when we talk a little bit more about physiology, things will make sense. So let's get started. This is always a nice topic to follow cardiovascular system discussions, simply because they work so much hand in hand. Okay, um, it's the respiratory system that is responsible for the exchange of the gases, to be able to take the oxygen out of the atmosphere, the air we breathe, and put it into the blood. It's the responsibility of the cardiovascular system then to take it where it needs to be taken, to the cells and the tissues. And then it's the responsibility for the tissues to be able to put the carbon dioxide into the blood. And then the cardiovascular system then takes that waste products, carbon dioxide, which is a waste, back to the lungs, and it's the job of the respiratory system to get rid of it. Okay, so basically the respiratory system and the cardiovascular system are go hand in hand. Okay, they're always going to be conjoined in what they do. So the idea behind the respiratory system is basically the air we breathe in with oxygen. It's only about 21% oxygen. The rest of the air we breathe in is actually most largely nitrogen. When we take it down to the smaller air sacs, and we'll talk about that later on, these alveoli, it's a very thin membrane, and the oxygen is able to diffuse across that membrane and to get into capillaries, which actually surround around this little bubble of a membrane, or the alveoli, which is actually it's cellular, but there's it's the inside's lined with a coating of a liquid called a surfactant, which we'll talk about later on. And then what happens is I have to get the oxygen through the wall of that alveolus and through the wall of the capillary to get the capillary. Then the cardiovascular system takes that, because that's happening in the lungs, which is through that pulmonary circuit, so it's from the right side of the heart. Then it goes back to the left side of the heart. Left side of the heart then takes the blood to the tissues and distributes it to the tissues. So it transports the oxygen wherever it needs to go, everywhere else in the body. Even the lung tissue itself needs an oxygen supply, which it gets through the systemic circulation, not the pulmonary circulation. Once it finally gets to its final destination, the oxygen is released, and then while there, the tissues say, hey, listen, we have a little carbon dioxide you want to take back to and deposit for us? And the cardiovascular system, trying to comply, says, oh, sure, we'll do that. They take it up, the carbon dioxide gets into the circulation through the capillary walls, gets into the blood, it's carried all the way back to the lungs, and the lungs then will put it through the capillaries around these alveoli into these little air sacs again, and then we can exhale the carbon dioxide, only to start again, pick up more oxygen, do the same thing. So that's the major thing that we talk about in regards to what the respiratory system does. We also know that what happens is also important in regulating pH. Now that doesn't make a whole lot of sense right now, but we've talked about homeostasis like almost in almost every class the whole semester. We've talked about the importance of homeostasis. Well, we know that what happens, the body likes to work within very strict environmental controls. Okay, and one of those things is the pH, which is the acidity or basic nature of the blood. The normal blood has a pH of about 7.35 to about 7.45, somewhere in that range, give or take a little bit above and below that, which is slightly on the basic side, because 7 is neutral, is neither an acid nor base. Low numbers are acids, high numbers are bases. And what happens is the way that they deal with the carbon dioxide basically allows both hydrogen ion or hydrogen atom, which is a positive charge, to actually be an acidic type of a compound, where the bicarbonate, the HCO3, is actually very basic, and it's sort of involved, but we won't talk more about that now. We may talk about it later on. We also know that the respiratory system is responsible for smell. We've seen those olfactory nerves, cranial nerve 1 that comes from the bottom of the brain that goes forward and finally gets to that cribriform plate with all those little holes in the ethmoid bone, okay, embedded within the frontal bone of the skull, and then with the crista galli it goes down, and then where those little nerve endings get to in the very attic of the roof of the nose, that's where we end up with all the sensory smell receptors that pick up the sense of smell. So that's that. We also know that the respiratory system does have an influence in regards to voice. And the reason why is if you take your hand and you stick it over that cartilage in your neck, okay, that little lump, that Adam's apple, guys, what happens if you talk, you'll actually feel a buzz. And the buzz is the fact that right behind there are the vocal cords. The vocal cords are two little cords. They're sort of like in the shape of a V. They come together in the front and they get wider in the back, and they're able to move closer and farther apart and stretch out, making tighter or relax and become more loose. And what happens is if I change the vocal cords by a bunch of little cartilages and little muscles attached to the edges of the vocal cords, it actually changes the character of the speech and stuff like that, or the pitch of the speech and all kinds of things like that, as air is taken from the lungs and moved out through the trachea past the area of the vocal cords, which then cause a vibration. And when you talk and you feel that vibration, that's some of that of the vocal cords actually vibrating, behind your fingers in that area of what's called the thyroid cartilage. So basically that's what the respiratory system does. Now, there are two parts of the respiratory system, and the first part we'll talk about, basically to get that out of the way, is the conducting portion. Okay, whoops, it did it again. Is the conducting portion of the respiratory system, and basically it's the part where it's just the tubes. No gas exchange is occurring in this. And basically what happens is a series of cavities and tubes that actually are able to transport the air from the outside through the nose and through the mouth down through the trachea and deep into the confines of the lungs. And basically that's about 150 milliliters, okay? And basically we have a number of things that are part of this conducting portion. Obviously the nose, okay? The nose becomes important in regards to respiration. I'll talk about that in a second. The pharynx. Pharynx just means throat. So the pharynx, there's the nasal pharynx behind the nose, the oropharynx behind the mouth, and the laryngeal pharynx behind the larynx. So that's important because that's on the way, okay? We have the larynx, okay, which is basically the area of the vocal cords, or the opening, or the entry point into the area of the trachea. Then we have the trachea. The trachea is basically a windpipe, and the windpipe actually starts just, if you feel that thyroid cartilage, you'll feel a little gap. Okay, and then there's a little gap, there's a little membrane, and there's another cartilage. It's called a cricoid membrane, or cricoid cartilage, and then the membrane is called the cricothyroid cartilage, or membrane just above that. And then below that we have the trachea, and you can feel the front, you'll feel rings. There'll be cartilage rings around the trachea, and I'll talk about that in just a little bit. Finally, when that trachea gets down to that area of that sternal angle, which we all know from, again, before in the skeletal system, which everything seems to come back and haunt us, is that junction between the nubrium and the body of the sternum, where the second rib is. The trachea divides. It divides to the right, which is a right bronchus, and a left bronchus. As we get further and deeper into the lungs, and through the lobes, each lobe, the lungs will have different lobes. Each time I get to in the right lung, I'll have an upper lobe, a middle lobe, and a lower lobe. In the left lung, I have an upper lobe and a middle lobe. So that bronchi, which one on the right, one on the left, when it gets to the lung, divides into each of the lobes. So there'll be 3 here, there'll be 2 here. Then they divide further and further into various what I call bronchopulmonary segments. They get smaller and smaller and smaller and smaller and smaller until I finally get down to what are called terminal bronchioles. Now, terminal bronchioles are very, remember we talked about arterioles. We're talking about arteries having sort of an elastic wall, where the bronchioles have or the arterioles have a muscular wall, which are able to either dilate and make the arteriole open, or contract and make the amount of blood flow through the arteriole less. Well, the same thing happens when I get down to the area of these terminal bronchioles. The bronchi are basically held open, and they're held open by cartilage rings. There's areas of cartilage that will actually hold open the bronchi. And I finally get down to terminal bronchioles, I'm losing that cartilage, and I'm starting to get muscle. I get muscle. You can't read it. There's muscle. Start to get muscle that's down around there, and the muscle's able to open or close. And that's either if it closes up, I have the decreased airflow through there. If it opens up, I have increased airflow. Okay, so that's what happens. Still no gas exchange. This is just a path. This is just a route. That's all it's going, and that's what we call our conducting system. Okay. The next portion we have is what's called the respiratory system. Now, this is where all the magic happens, okay? This is the area that the lung, if I took a lung and threw it on a table, there'd be weight to it. It would be sort of big and sort of full. What happens if you cut it, there's millions and millions of these little air sacs in there. And these little air sacs are called alveoli. And these alveoli, the walls of the alveoli are about 1 cell thick. okay? And they have a membrane on the inside, which is basically a fluid membrane. But to get to there, I need to have these, what I call respiratory bronchioles. Now, these are the bronchioles that are leading right into what are called alveolar ducts, which then the alveolar duct leads into the alveolus. So we go from the respiratory bronchioles, which have muscle around the outside, to alveolar ducts, to then all of a sudden into the alveoli. And alveoli is where I have all this gas exchange that occurs in the alveoli. And I'll talk a little bit more about that probably maybe a little bit today, but at least in the physiology portion. So basically the respiratory system, which is actually much larger in capacity, 5 to 6 liters as compared to about 150 milliliters, but 5 to 6 liters is where all this gas is exchanged. One of the problems we get is certain diseases and conditions such as emphysema, where the lungs become trashed. And what happens is we lose the structure of a lot of these alveoli, and we have larger air pockets that'll form inside the lungs. And guess what kind of gas exchange occurs in these larger pockets? You're right, nothing. So as a result, they lose a lot of functional lung capacity. So this 5 to 6 liters that we have of our normal, it starts to go down and down and down and down and down and a lot more and more as time goes on. And that's what happens with things like emphysema. So basically this respiratory portion is important because that's where all the gas exchange occurs. The oxygen from the air into the blood and the carbon dioxide from the blood into the alveoli to be able to exhale. A couple terms I think that are important to know is one is called pulmonary ventilation. Ventilation is a mechanical process. Okay, ventilation is a mechanical process, and basically this is the movement of airflow into and out of the lungs, and that's a mechanical process in regards to certain things that happen to allow this to happen. You know, the intercostals, the external intercostals are important, the diaphragm is important, and this is what's causing the the mechanical process of air moving in and out. Okay, but what happens is we have to think about a little bit more about the physiological process, and that's what we have what's called respiration. Ventilation, mechanical. Respiration, physiologic. External pulmonary respiration is basically where we have exchange of gases between the lungs and the blood. When we breathe in the air, what happens is then the oxygen goes from the lungs, from these little air sacs, the alveoli, into the blood. That is external pulmonary respiration. Finally, because it's from the outside, external makes all the sense in the world. Then we finally have what's called internal or tissue respiration. And the internal tissue respiration is now when the cardiovascular system takes that blood with the oxygen to the tissues, wherever that might be, tip of the little toe, or tip of the big toe, back of the knee, wherever in the body it needs to go. Even the lung tissue itself needs to have a blood supply so the tissues and the cells in the lung will still survive. Okay, so everything that needs blood with oxygen to survive, which is basically almost all living cells, there's a couple exceptions to that, okay, basically now we have the oxygen from the blood that goes into the tissues, and that is called internal or tissue respiration. So those are two important terms you need to know. So let's talk about the anatomical considerations for the most part for the rest of the session. Let's talk about the nose first of all. The nose we take for granted, okay? See it on everybody's nose and stuff like that, on everybody's face. It's part of what we call the upper respiratory tract, okay? And basically we have both an internal and an external portion. The internal portion is the part on the most, close to the outside, and the internal is way in the back. It's divided all the way to the back side by the nasal septum. That nasal septum anteriorly is very flexible because it's cartilage. As I get further back, I get closer to that area of the vomer, okay, where it becomes more bony. But it's divided right and left side. If I look at this external nose, and this is what we see, we're talking about this area in here is my external nose portion. We know that what happens is the nose has a certain shape to it, and it's shaped mostly by cartilage. The first bone I have is around the outside of that piriform aperture, and my nasal bones, the two little nasal bones up here at the top. The rest of the nose structure is basically by cartilage, about either the septal cartilage in dividing the right side and the left side, or all these other cartilages that are around out the outside of the nose. You could read what those cartilages are. Probably more important than the cartilage, and again, the cartilage is relatively flexible. What's more important than the cartilage is the inside of the nose is lined by a mucous membrane, okay? And I'm going to talk about that in just a second, so hold on to that. It's lined by a mucous membrane, and when you feel inside your nose, if you're really, by yourself and you don't care what people say, and you feel inside your nose, it's going to be sort of slippery and slimy inside there. We know that the nose is basically created by the frontal bone, which is, if I look at the area of the frontal bone influence into the nose, it's just up in, well, it's not even showing up here. Let me see if I could do it this way. Up, well, it's not doing it very well either here. Up in there and on the other side. If I look at the most of this piriform aperture is actually formed by the maxilla, which the maxilla is that big. It's about 2/3 of the way around is that piriform aperture. And then up in here, I have a couple little nasal bones that sit up in here, and that's all that makes up the nose. That's the major portion of the external portion of the nose, those three bones. Again, that septal cartilage, it's flexible. Take your nose, you can move it back and forth, and you realize it is because that's that flexible cartilage, okay? There's also a lateral, the alar cartilage. Remember the lever labii superioris aliquote nasi muscle? Well, what happens is this aliqui or ali is basically this area right here, that little airway flared. Now, I talked about that mucous membrane being important. It's important for a couple reasons. Number one, it's important for warming. Number two, it's important for moistening. And three, it's important for filtering the air. What happens is the nose has a lot of small blood vessels in it. If you look at the septum, there's an area on both sides of the septum. They're on the septal wall on both sides of the septum that has a very abundant blood supply. It's called Kiesselbach's plexus. When people get a nosebleed, that's almost always where it comes from. But the nose has a lot of blood supply to it. Now, what happens is, if we think back about it when we talked about the nose or in the skeleton, remember the conchae? We talked about the conchae bones, okay? What happens is these conchae provide a greater surface area so I can have more mucous membrane. It creates a greater area where I could actually warm more. Now, why is it warm? Well, if there's a great blood supply, blood's warm. That warms the air. So we warm the air through the nose. In the winter, when people don't breathe through their nose and they breathe through their mouth, they're more likely to have inhale more stuff because the nose also will filter. I'm going to jump to 3. It filters. Inside the nose, if you want to take a look for it when you go to the bathroom tonight, go look in your nose and you'll see all these little hairs in there. Well, those hairs are like little webs. They're able to trap material that I sort of inhale through my nose. So if I inhale dust mites, which are small little bugs, all these type of things that I'm bringing in, they may stick and be caught in this web of the nasal hair on the inside of the nose, okay? As well as the mucus on the inside of the nose that goes all the way back, the mucous membrane goes all the way back even to the back of the throat and then all the way down towards the trachea. What happens is the mucous membranes making this mucus, they also become sticky. So when those particles hit that, they stick to it. They create the clumpy things that you have to choose out, do a little nose mining every so often to get all those clunky things out. But basically, a lot of that is garbage that's been inhaled in and that caused the mucus to sort of get hard and stuff like that. And so it traps a lot of that stuff. Some stuff gets further on down, and I'll tell you what we do about that as we go further on deep. We also know it moisturizes, because in the moistening occurs because those mucous membranes are wet with the mucus. So it helps to moisturize. Perfect things we want. We want air that's warm, we want it humidified, and we want it clean, just like we want in our house, okay? Also, we know the nose is important in detecting olfactory stimuli. That's a no-brainer. We talked about the olfactory nerve before. Also, it's also important in modifying speech. Some things we actually our speech is affected on what comes out our nose. You gotta remember at the back of the throat where that soft palate is. If I go up behind that, I can actually come forward and actually come out through my nose. I wouldn't do that. You have to have a really long finger. Okay, maybe ET. But what happens is the back of the nose is continuous with the back of the mouth. So basically, when air comes up, if this goes through the vocal cords, sometimes the nose acts as sort of like a resonating chamber that will change the speech characteristics. Okay. Now the internal portion of the nose is this area in here. Okay. Whoops, it's doing this again. Let's hope that didn't cause a problem. Every time I touch and something goes wrong here, there's this portion of the nose right there, and basically the anterior portion is called the vestibule. Now the vestibule has these little ridges in there, and these little ridges, or they're shelves that are in there, are called conchae. Okay, or they're covered with the conchae, and they're actually when they're covered with the mucous membrane, they're called turbinates. Okay, and these turbinates are basically mucous membrane shelves, and what they do is they increase the surface area so we could trap and filter more stuff. Okay, and that's what they do. Okay, so there's actually an inferior, a middle, and a superior shelf in there, turbinate, and then underneath the second one, underneath the middle one, right underneath this one right here, just underneath that, basically most of the sinuses, the frontal sinus, the maxillary sinus, ethmoid sinus, and the sphenoid sinus, not all the ethmoid sinuses, but a couple of the ethmoid sinuses, and the sphenoid sinuses actually have ducts that will empty into the nose in this area right here, underneath that middle turbinate that's right there, okay? Posteriorly, I get to what's called the posterior nasopharynx back in there. Okay. Now there's one other thing that I should mention inside this vestibule region. There's also what's called the nasolacrimal duct. The nasolacrimal duct. And what happens is the nasolacrimal duct, if you the lacrimal gland, the tear duct, actually is in the upper outer portion of the orbit. So what happens is when it normally creates secretions to keep the eyes moist, it comes across the eye from lateral to medial. And if you look at the medial side of the eye, there's that little pinkish puffy thing that's in the medial, which is called the inner canthus in there. That little area, that pink area, if you look really close, there's a little hole in it. That hole is basically the beginning of this nasolacrimal duct that goes down to the back of the nose. That's why, and we're going to solve another of life's mysteries in Bio 1221. When people cry, why do their nose run? Their nose runs because what happens, the tears come across, part of those tears go down the nasolacrimal duct, they get inside the back of the nasal, in the area of the vestibule, and then it comes out your nose, and that's why it happens. So when your nose runs and you're crying, guys, that's why it's happening, okay? So that's what we see there. There's one other area back there that I should show, and basically, let me see if I could erase this stuff right here. Erase it. If I see I touch my screen today, it sort of shuts off for a while. If I look back here, there's a little opening right there, okay? And that opening right there, okay, is called the eustachian, is the opening of the eustachian tube or the pharyngotympanic tube. Pharyngo-pharynx, tympanic, it means ear, okay? And what happens is, for hearing to occur, when air comes through my ear, it goes down the canal and causes the tympanic membrane or the eardrum to vibrate, okay? So I have to have equal pressure on the outside of the tympanic membrane, eardrum, as compared to the inside of the tympanic membrane, eardrum. They have to be the same pressures. They can't be different. What happens is what keeps that pressure is this tube that stays open. When that tube closes, I can't equalize pressure behind the area of the tympanic membrane, eardrum, and as a result, it gets sort of sucked back. You ever notice if like you're in a plane and you're going up in altitude and all of a sudden your hearing gets muffled? The reason why it is because the pressure in the cabin causes that eustachian tube, pharyngotympanic tube, to sort of close off a little bit. Therefore, what happens, I can't equalize pressure behind my eardrum. The pressure behind the eardrum is lower than the pressure outside. The eardrum gets pushed back, almost like it's sucked back from the middle ear, and as a result, it doesn't vibrate. It doesn't vibrate the same. The vibrations become a lot less. So your hearing goes down. Well, what do? You swallow, you force your breath out. What happens? That forces open the eustachian tube. Now it equalizes pressure and everything's fine. So basically that's what we have in this internal area, okay? So I think that all those things are important for you to understand. Again, just a review of what happens in the nose and why the nose is so important. Air is warmed by the blood. Perfect, okay? Air is moistened by the secretions and mucus that's inside the nose. Perfect. Air is filtered by the nasal hair and gets trapped in the mucus. Perfect. We have air, we smell by the olfactory, sensory, and nerve endings in our nose. Perfect. And then we use the nose again for speech as a resonating chamber for certain different sounds. All these things come together, and all those things are quite important when it comes to what the nose really does. Okay. Now we're going to get to the area of the pharynx. Pharynx is way in the back. Okay. Now we're talking about back in here. Okay. The area behind the nose is called the nasopharynx. The area behind the mouth is called the oropharynx. Okay. And the area behind the larynx is called the laryngopharynx. Okay. So that's there, and that's up in here. So we have it's a continuous tube, okay, from the back of the nose to the back of the throat to the back of the larynx, okay, and basically it's also lined by mucous membranes, okay, which is quite important, okay, and so that also helps to trap material. let me just jump the gun here. Some stuff, some small amount of particles make it all the way down into those little air sacs. Well, what happens to them? Well, first of all, bacteria are small. We don't want bacteria sitting down there growing and stuff like that. Inside those little air sacs are a thing called macrophages. Macro means large, phage means eat. They're like white cells that walk. All they want to do is eat stuff up. And basically all these smaller particles like bacteria and stuff like that that get down in the air sacs, these alveolar macrophages take care of them. They just sort of digest them when they get down to the area. Okay, let's talk about the nasopharynx. The nasopharynx back in here, okay, we'll be talking about this area back in here, and there's our eustachian tube right there. The nasopharynx is lined with pseudostratified ciliated columnar epithelium. Now, where did we see this before? Sure, of course, the intestines. And the reason why we had pseudostratified ciliated columnar epithelium is because I need to make glands to be able to make the mucus. The glands are tall, so therefore the cells have to be tall to be able to support on both sides. The columnar cells have to be able to support the glands between. This is also the location, and let me erase this thing so I can show you a little bit more. This is also the location of what we call the pharyngeal tonsils. Okay, the pharyngeal tonsils we also know and love called the adenoids. They sit right back in this area, back in here. Okay, people who have a lot of allergies, these adenoids get large, and what they do is they sometimes get so large that what they do is they block this whole nasal pharyngeal area back here. So therefore, air that comes in here can't get past that. Okay, that's why people sometimes have a tonsillectomy. They remove the tonsils in the throat as well as an adenoidectomy, and they take the adenoids out to allow them to be able to breathe better. Okay, I know my daughter just before spring break had a tonsillectomy and adenoidectomy, and she's 5, and basically she did pretty well. But anyway, the adenoids are sitting back there, okay, because she had all kinds of infections and stuff like that. So anyway, that's the adenoids back there. They're called the pharyngeal tonsils. How many sets of tonsils do we have? You're going to say 2, one on one side, the other side. You actually have 3. Whoops. You have 3 pairs. And the one of them is going to be the adenoids, sits back in there. Okay. Here's the auditory tube, eustachian tube, pharyngotympanic tube, and stuff like that. That's back in there. And what happens is that nasopharynx descends and ends right here at this area. What's that? That's the soft palate. This area up in here is the hard palate. This area back here is a soft palate. And again, when we swallow with cranial nerve 9 and 10, glossopharyngeal and vagus, what will happen, it raises the soft palate and seals off. It seals off back in here, so therefore I don't have peas and stuff coming out my nose. Okay, so basically that's what we see in our nasopharynx. Okay, should be pretty simple to think about. Below my nasopharynx, I have my oropharynx. Okay. My oropharynx is basically lined with stratified squamous epithelium. We lose the columnar. We stop making the mucus when it gets back of the throat, but we need it to be moist. Okay, so other things will secrete some. The secretions that we get back there are not so much from glands that we have in the back of the throat, but more so from the saliva that keeps that area moist. So now we're talking about this area between about there and about there, and that's the oropharynx. This is the location of the palatine tonsils. Now, what are the palatine tonsils? The palatine tonsils are those 2 suckers that you see sitting on both sides, one on each side, one on the other side. And that's my second set of tonsils. I have my pharyngeal tonsils, or the adenoids. I have my palatine tonsils, which are suspended from the palate, from the soft palate to the floor of the mouth on both sides. And then at the back of the tongue, back in this area, I have a third set, which are called lingual tonsils. Lingual tonsils. And basically what happens, this is sort of an interesting thing, you probably you don't have to remember it, but if I look in the mouth, there's actually a ring of tonsillar material that goes all the way around. I have my pharyngeal tonsils up here, I have my palatine tonsils over here, I have my lingual tonsils here. It creates a ring around the mouth. And that's basically, what are the tonsils? They're like lymph nodes, and they're the same type of tissue. They're lymphatic tissue. So what they do is they trap material, and they're able to get rid of them. You know, bacteria, viruses, and stuff like that. That's why people get a you know, strep throat or viral sore throat, because and then also you notice that what happens when you get a sore throat, what happens? Oh, you got the swollen glands in your neck too, and you feel those little lumps there. That's because since these tonsils are also lymphoid tissue, they drain to the lymph nodes in the neck, so the lymph nodes in the neck will get large. So basically, we have our palatine tonsils. Okay, we have our palatine tonsils and we have our lingual tonsils on there. This goes all the way down to the area of the hyoid. Now, the hyoid, you could feel a little bit. We talked about that. That's a bone that doesn't articulate with any other bone. In other words, that would have been a great lab question I did. But a hyoid is the one bone that doesn't articulate with any other bone. It's suspended by muscles. Okay, and it's sort of like in front of the area of the thyroid cartilage. Okay. Now we get down to the laryngopharynx, and the laryngopharynx is the area that's down in here. I should use a different color. This area down here is the laryngopharynx, okay? And this is basically goes all the way from the hyoid, and we could see the hyoid would be right here. That would be the hyoid, that little yellow thing that's right there, all the way down to the area of what's called the cricoid cartilage, okay? Now, if you feel your neck again, you feel that Adam's apple, you feel that area, that's the thyroid cartilage. Now if you go down sort of like a V on both sides, it comes out like this with little wings. If you come down below it, you're going to feel a little gap. And that little gap is where there's a membrane, and it's called the cricothyroid membrane right there. And there's a ring of cartilage that's just below that, which is called the cricoid cartilage. And that's the lower edge. So that's down in about this area, right down in there. The thing about this laryngopharynx is, I'm going to get these out of the way so you can see, okay? I have two roots back here. This is where the tracts diverge, okay? If I want to eat, okay, what happens? Food comes in the mouth and goes down posteriorly, and the esophagus sits right there. If I'm going to breathe, what's going to happen? Air comes in the mouth and goes down this way through the area, and the vocal cords would be sitting right there. And the air is going down this way. So what we have is the esophagus sitting posterior to the trachea, which is anterior. Interesting thing enough, what happens is the front side of the esophagus and the back side of the trachea are stuck together by muscle. They're actually this almost like it's not really totally singular, but it's almost like a merged wall. The posterior side of the trachea and the anterior side of the esophagus, they sort of sit like that. Okay, so back here at the back of the laryngopharynx, we have both the respiratory as well as the digestive pathway. Okay, what stops it? This is a cool thing too. See this? There's a little tab back in here. Okay, and that little tab is called the epiglottis. Epiglottis. Oh, I can't write it because it keeps on turning off. Epiglottis. Okay, epiglottis. It's a little flap, and when I swallow, I'm swallowing food. That flap closes over the opening of the trachea and the vocal cords, so food goes down the back. And when I want to breathe, that epiglottis opens up to allow the airway to be open. Normally, if there's no food going down the esophagus, it's flat. It's sort of flat front to back. So it's not like an open tube all the time, but it's flat front to back. Okay, so that's the back part right there. Now, what happens is that pharyngeal physiology provides for conduction of air all the way to the level of the larynx, where then all of a sudden it's turning it over. Provides a conduction for food to the level of the esophagus. Esophagus posterior, trachea anterior, and also acts as a resonating chamber for speech. Also, we're still at the vocal cords, so therefore that's what's going to cause a lot of that speech and the vibrations that will cause that speech. Okay. Let's talk about the larynx for just a second, and that larynx is basically complex, and I don't want to spend much more than a couple seconds on this, very, very short, because we had a lot of other important things to talk about. And what happens is we have that thyroid cartilage, like I mentioned, which is the big one, and then a cricoid cartilage, which is just below it, and then then we have that cricothyroid membrane between. Around the rim, right where the trachea starts, okay, there's a rim, okay. And a couple of little cartilages are attached to those that are like little pivot areas, and they're attached by muscles. And these muscles will open or close, which allows the vocal cords, which is closed in the front and open in the back, allows the vocal cords to open or close, depends upon the muscles working on these small little cartilages. Okay, that's all I want to say. And then I want to also re-mention again the thing about the epiglottis, which is a flap that closes over the trachea when we eat to prevent food from going down the trachea. Okay, we don't want food going down the windpipe. It's a bad spot. If you've taken CPR, they teach you about things like the Heimlich, where they have to squeeze and try to pop that stuff out. The problem with people when they usually have a problem where they need to have the Heimlich is because they're eating and talking at the same time. The epiglottis doesn't know if it should be open or closed, open, closed, open, closed, open, closed. And finally, what happens is it catches it in between, and I got a piece of steak that gets junked down right between the vocal cords, gets lodged in there, and that's what you hope that Heimlich is going to be do. And what the Heimlich does, it takes, you go underneath the diaphragm, push the diaphragm up with a real quick burst, and the idea is to hopefully when you push the diaphragm up, any air that's in the lungs is going to be pushed up out the trachea, and it's going to cause enough pressure that's going to expel like a cork out of the end of a cork gun, you know. And basically that's what we see there. Okay, and that's the trachea. That's what the larynx would look like. So this area up in here would be the hyoid. There's a hyoid down here. Here's the thyroid cartilage right here, and here's the cricoid cartilage below that. There's the thyroid gland. That's just right there, which is around that as well, which is a very vascular structure, which is the reason why they sometimes have to be careful when they do a tracheotomy, because it bleeds like a fish. Okay, so anyway, that's about that. And this is just looking at the glottis. The glottis means the opening between the vocal cords. So there are two mucous membrane folds with a space, and this is the vocal cord here, and you can see how in the upper one it's open, and the lower one it's closed. Okay, and that's because these little cartilages with little muscles will actually open or close these things, and that's what the vocal cords do and what the glottis does. We also know that on the sides of the vocal cords there are flaps. Okay, in other words, it's not just a cord over an open hole. But if I had the ring for the opening of the trachea, okay, and if I had the vocal cords going, no, that's not a good way to do it. Vocal cord going this way, that's even worse. Let me do it this way. Vocal cord going this way and vocal cord this way. This area in here is filled with a membrane. So the only way to get air through is through the opening between the two vocal cords. So what happens is that allows, when you close those vocal cords, to develop a significant amount of pressure inside the thorax. Okay, and again, those true vocal cords, like we talked about, are what resonate to produce speech and stuff like that, because of the way the little cartilage that are attached by muscles will open or close to open or close the vocal cords. Okay, thicker vocal cords produce the lower pitches. Thinner, which is basically more stretch out, causes a higher type of a pitch. Let's get down to the trachea. Trachea is the windpipe. Okay, now the trachea starts, at the area of the larynx and goes down to where it divides. Okay, which is that's the area we talked about before called the carina. Carina means keel, like at the bottom of a boat, which is a V, and that's because what happens is at this point down here is we have the trachea dividing into a bronchus that goes this way and a bronchus goes this way in that little keel, that little upside down V-shaped. Okay, so we know it's anterior to the esophagus, and that the posterior aspect of the trachea is consistent and stuck to the anterior portion of the esophagus. What holds the trachea open, and you can actually feel them. If you feel your neck, you'll feel little rings around the trachea. Those are cartilage rings, but the cartilage rings only go about 2/3 of the way around. They're open in the back. Okay, and probably because if they were closed in the back, if the cartilage rings went all the way in the back, it would be sort of an obstruction to swallowing. Because what happens is then it's going to put pressure back against the esophagus. So this way, because that posterior wall of the trachea is muscular with the anterior wall of the esophagus, I don't have the rings back there because it's not going to interfere with swallowing. Okay, so that open part of the C, so what happens is that these cartilages. Let me just draw another picture here. Let me just draw something like this. The cartilage, come on. Cartilage goes around this way, and it's open in the back. So this would be the esophagus back here. This would be the trachea, and the cartilage only goes part way around. So this way right here has no cartilage. Okay, and we talked about the carina in the area. And the carina is the area of the cough reflex. So the cough reflex would be right in about this area right here, where there's special cells there. When we get garbage and gunk that's brought up there, I'll tell you how it gets there in a second. Garbage and gunk that gets in there, we're able to cough and expectorate and bring that stuff up. Okay. Now, what happens is the trachea is lined with pseudostratified ciliated columnar epithelium, okay? And they also have goblet cells. Now they're making mucus again. Rather than relying upon the saliva, they do have mucus glands that will make mucus, as well as cilia. Now, these cilia are small hairs, okay? We saw them again in the intestine. What they do is they have a muscle that beats, and they beat upward. okay? And the idea behind the cilia and the mucus is they trap stuff that we breathe in, stuff that wasn't filtered in the nose or stuck to the back of the throat or in the tonsils or something like that. They get down the trachea, and what happens is hopefully we're going to trap more of those in the cilia, and then the cilia will beat. They move upwards, and they sort of like body surf pieces of material, bacteria and stuff like that, up towards the carina. And when they get to the carina and the garbage gets in there, then what happens is then that stimulates that cough reflex, and they can bring it up. So these cilia are important. What's the significance of this? One of the significance is that some of the toxins in tobacco smoke paralyze the cilia, and that's why we see when people with a chronic bronchitis and emphysema, who do we usually see that in? Smokers. And the more smoking they do, the worse it is. And the problem is that for many years with smoking, they actually decrease the function of the cilia, and the cilia all of a sudden, yeah, I'm not going to do anything. I'm done. You know, you guys keep abusing me. I'm not going to do anything. As a result, now all this garbage and debris gets stuck inside their lungs. There's nothing to bring it up because the cilia is actually moving it towards the carina. There's nothing to move it up, and it causes infection after infection after infection. And those infections then cause destruction, fibrosis, all kinds of problems, which then results in destruction of some of the connective tissue in the lung, which then causes the emphysema and all kinds of problems. So the moral of the story is don't smoke. It's really simple. I mean, unless you want to trash your lungs, okay? What happens is, finally, when I get down below that, I get to the area of the bronchi, okay? And what happens is when I get past the carina, I have bronchi. And bronchi are large airways, okay? We have a bronchus that goes to the right and a bronchus that goes to the left. Couple interesting facts about the bronchus. First of all, the right lung here has 3 lobes. It has an upper lobe, has a middle lobe, and has a lower lobe. The left lung has an upper lobe and a lower lobe. So what happens is when this bronchus breaks off, okay, or divides off the trachea, okay, what happens? It has to go part of that will go up. Part of it will go to the middle lobe, and part of it goes towards the lower lobe. Okay. What we find is the opening for the right, what's called the right mainstem bronchus, is bigger and more vertical than to left. Left only has to go to the upper and to the lower, and basically it's more horizontal. Okay. It's smaller. It's more horizontal. The right is more vertical, and it's wider. Okay. When a kid sort of like swallows a bead or something like that, the place that they usually look for it is down here. That's the most direct route to get down to the lower lobe. Okay. So what happens? I get what's called a primary bronchus, which is still pseudostratified ciliated columnar epithelium. Again, trapping particulate matter. Again, opening the right lung wider, more vertical than the left lung. Then what happens? I get down to what's called the so that's in this. So my primary bronchus is this area and this area. Then what happens? I get to what's called my secondary bronchus. I have a branch that's going to go that way, branch is going to go that way, branch is going to go that way, branch is going to go this way, and a branch is going to go that way. Okay, and basically those are my secondary. And then what happens is then we get to smaller and smaller what are called bronchopulmonary segments, and these bronchi, these secondary bronchi, then branch into tertiary bronchi, and then they branch into more and more and more as they get smaller and smaller and smaller. Okay, as they get smaller, what happens? They lose that cilia, and the cells get narrower or smaller. Instead of being columnar, now they become cuboidal, non-ciliated cuboidal when it gets further on down. So we do see some changes. What's the problem? Stuff is going to get down there. Hopefully the nose, the mouth, the trachea, mainstem bronchus, and up in the earlier portions of the secondary bronchi have trapped enough of the garbage that it doesn't get down there. But if it does get down there, what traps it and what takes care of it? Those macrophages, those big white cells that go in and eat up all the garbage to finally get down to where they're not supposed to be. Get out of here, kid. You're not supposed to be here. And that's what the macrophage will get. Okay. Again, when I get down further and farther, we also, besides losing the cells going from columnar to cuboidal, and besides the cilia being lost, okay, because again, we can't have cilia, we don't really have cilia too much in cuboidal cells. What happens as I get further and deeper in the lung, I lose cartilage. Okay, and that cartilage in the mainstem bronchus now is all the way around, okay, and all the way through all these other secondary bronchi and stuff like that. But as I get further and deeper in the lung, I get less cartilage, okay, as they branch with more smooth muscle lining. And the idea here is, again, you get to a certain point when you want to get down to these things called bronchioles, like I talked about earlier. Like an arteriole has a muscular wall, bronchioles have muscular walls. So as a result, what happens is if there's an area that doesn't need as much air, those muscles can contract and decrease. But if I have an area that needs more, those muscles will relax and open up to let more air come in. Also, these are very active. When I finally get down to these muscles, okay, the muscles are very involved with what's called parasympathetic activity and histamine, release. When people have asthma, what triggers asthma? Well, there's a couple things that are common, but the most common is probably allergy. What does allergy do? People then get a rash. Why do they get a rash? Because the body releases a chemical called histamine, and the histamine is one of the things that starts to cause this rash, or the hives. Well, guess what? Histamine also causes these bronchioles, the muscles of the bronchioles, to constrict. Histamine makes blood vessels dilate, but makes the bronchioles constrict. Okay, so as a result, what we see with asthma is the bronchioles, the bronchioles start to constrict because of the allergic influence that starts the histamine going and stuff like that. So what they do, and they find out that histamine has very parasympathetic activity. Okay, very parasympathetic activity. We mentioned that the GI tract, but also the lungs work opposite the cardiovascular system as well. What happens is where histamine will constrict bronchioles, it dilates arterioles to increase the blood supply. Okay, so what happens is that's why people, if you've had asthma, if you know anybody with asthma, what they frequently do is they give them something like epinephrine, and epinephrine will constrict blood vessels, but guess what? Constricts arterioles, but guess what it does to bronchioles? It dilates them. It makes them big. So as a result, they usually give epinephrine, and epinephrine makes the asthma go away, or they also give bronchodilators, and that will actually cause those smooth muscles in the bronchioles to dilate, to open up the bronchioles to get more air in. Okay, asthma, by the way, is an air trapping problem, where what happens, the problem is you get plenty of air in, but it's very difficult to get the air out. If you get an x-ray of a kid with asthma, man, their lungs look like they're hyperinflated, like they're overinflated, like they're all full of air. And the reason why is because they are. Because what happens is they could get the air in, but the air gets stuck in these alveoli. Okay. You could actually evaluate the bronchial tree by bronchoscopy or bronchogram, where they could actually either, they could go in and actually look inside with the scope and look inside some of these larger airways. And then sometimes on radiographs, on x-rays, you'll actually see people with certain lung disease, you'll actually see the bronchi, and there'll be two parallel lines. They're called tram tracks. And they look like two parallel lines, which are basically the walls of some of these larger airways getting so thick and irritated and fibrotic and scarred that you actually see them on x-rays, which is a pretty ominous sign. Okay, a couple things about the bronchial physiology. Okay, again, asthma, we talked about this already as an air trapping, with bronchoconstriction, with the air trapping we talked about. And again, I treat it with something sympathetic like epinephrine and bronchodilators to relax those bronchial muscles, to allow them to open up. As a result, they will allow more air in. Also, did you notice that when you exercise, that what happens is you may breathe faster, because the sympathetic activity is doing what? It's making your heart beat faster. It makes your respiratory rate faster. It makes your blood pressure go up a little bit. It makes the contraction of the heart faster, but has the opposite effect on the lungs. And sympathetic stimulation actually causes the release of epinephrine and norepinephrine from the endocrine system, which actually will dilate the bronchioles, which allows and improves ventilation during exercise. So when people have a clearer breathing when they exercise, why? Because while their blood pressure and their vessels are squishing down, because the sympathetic activity will affect the arterioles to squish down, increase heart rate, it actually does the opposite for the bronchioles. It allows them to dilate and open up. So it increases the airflow when I need it more, because I need more oxygen if I'm exercising. Makes sense. That's just a logical thing. About the lungs, okay? A couple things about the lungs. Okay, first of all, what we know is the lungs are part of the lower respiratory tract. Okay, we've talked about this before. On the outside of the lung, we have what's called the visceral pleura. That's that membrane, a serous membrane that's on the outside of the lung. Just like the PU is on the outside of the brain, the visceral pleura is on the outside of the lung. Covers the lung on the bottom, the top, the sides, the inside, on the medial side, the whole bit. Okay, what happens is when it gets to the hilum, or the center portion of the lung, it folds back on itself and lines the mediastinum and the chest, and all the way around, also the top of the diaphragm. And so what happens is that membrane starts out like this, comes around like this, and when it gets to the hilum of the lung, it turns back on itself like this, And what that does, it creates a space between, which is called the pleural space or the pleural cavity. And that parietal pleura and visceral pleura are both serous. What do serous membranes do? They make serous fluid, which is that slippery fluid. Okay. Sometimes if I have an opening, what will happen either from the inside or the outside into this cavity, air gets in there, and when air gets in there, that's called a pneumothorax. So now when air gets inside this space between the visceral and the parietal pleura, the lung gets smaller and smaller and smaller, and the whole lung cavity fills with air, which then causes a problem because I can't exchange gases. Also, it takes the whole mediastinum and pushes it the opposite way, which puts a lot of pressure on the heart and may cause death. Okay. If I have blood that fills in this spare space right there, let me get a little blood in there. Come on. For some reason, my thing is not working the way it's supposed to. Okay. If I get blood, and it's showing up dark, it's supposed to be blood. Okay. If I get blood in there, that's called a hemothorax. The thing about blood is basically it's heavy, it's liquid, so it falls to the bottom. So basically, when it displaces the lung goes up, and the lung fills more and more with blood down here. That's when they put in a chest tube for both of these. They put a chest tube in there to suck the blood out or suck the air out. Okay. We also have a situation where sometimes with cancers or other things like that, it fills with other types of fluid, and that's called a pleural effusion. Inflammation of that membrane is called pleuritis or pleurisy. Okay, which you've probably heard about in the past. Okay, and that's, whoops, it's all in the way. Let's talk about the lung, a couple things. First of all, the lung, the top of the lung is called the apex, the bottom of the lung is called the base. Apex, base, base, apex, base. So that's that. We have the mediastinal surface, which is against the mediastinum. We have the diaphragmatic surface. We have the area of the costal surface, which is against the ribs. One other thing I want to show you here is this area right here, and that's called a hilum. Okay, and that's on the mediastinal surface, and that's where the bronchi go in, where the blood vessels, where the pulmonary artery goes in, where the pulmonary vein comes out to go towards the heart, and that comes in one area just there. I can't have it around the outside because I wouldn't be able to expand the lung very well. Okay, I mentioned this before, that what happens is the left lung has an upper lobe and an inferior and a lower lobe. Superior and inferior lobe, and what they do is they have what's called an oblique fissure that divides it. If I look here, here's my oblique fissure coming across like that. Okay, my right lung, okay, has three lobes. It has an upper lobe right here, has a middle lobe, and a lower lobe down in here. 1, 2, 3, and it's divided by what's happened by two fissures. Okay, so what happens, there's an oblique fissure, which is this one here, and a horizontal fissure, which is here. So I have a right upper lobe, a right middle lobe, and a right lower lobe. Okay, and again, the hilus is where everything enters or leaves the lung. So these are the fissures and stuff like that. And you know, so again, if I draw that, here's on my right lung, here's the oblique, here's the horizontal, and on my left lung, here's the oblique fissure right there. Upper lobe, lower lobe, upper lobe, middle lobe, lower lobe. Okay, and that's what we have. Okay, again, each lobe receives that secondary bronchus. The primary bronchus goes into the lung. Once it gets into the lung, I have a secondary bronchus that goes to the upper lobe, middle lobe, lower lobe on the right, and the upper lobe and the lower lobe on the left. Okay, and then what happens, it goes further and further on down, called bronchopulmonary segments, as I get further and further on down the chain. Now finally I get down into the area where that makes a difference, okay? And this is where we finally get to what are called lobules, okay? And this would define what a lobule is, okay? What happens is I've gone through my the bronchi that get smaller and smaller and smaller, and I start to replace those bronchi with bronchioles. The bronchioles start to have muscle. I finally get down into here where I get what are called respiratory bronchioles. Okay, and these are the ones that are in this lobule that are leading to these little air sacs. Here are the tons of little air sacs down there. And what happens is these little air sacs are fed by alveolar ducts, or small ducts that will go there, and the alveolar ducts lead to alveolar sacs. Okay, now the lung is filled with millions of these little grape-like sacs all over the place. And these little grape-like sacs are all over the place, all have a duct that goes into them. They're like one cell layer thick, okay? The wall is. They're very thin because I want something that's going to be easy for the oxygen to get across. Okay, so that these alveoli that make up the lungs are all these little sacs, and I want to have something that makes it easy for the oxygen to go across and the carbon dioxide to go across that membrane. Okay, so this is the area. The alveoli is the area where the gas exchange is. It's a functional unit of the lung. The functional unit of the lung. Okay, now what holds these little air sacs are so darn small. What holds them open? Inside the little air sacs, there are little special cells every so often, and what they do is they create a liquid that's called surfactant. And that surfactant is a liquid that coats the inside that holds it open. Why do you think bubbles, when people blow a bubble, why do you think those bubbles sort of float in air and they stay? Why don't we just have that soap just drop to the ground? You blow in it and the soap drops to the ground. Because what happens, it creates a tension that allows that air to be trapped in there. So the inside of the alveoli have a very thin layer of fluid in there, and that fluid is called surfactant. When they talk about a baby who's being born prematurely, what's one of the biggest concerns? Oh, are their lungs mature enough? Well, one of the problems is these cells that make the surfactant don't come until later in pregnancy. So as a result, if you have a baby who's born before a time when these cells are making the surfactant, they can't keep the alveoli open. That's why they have to stick the baby on a ventilator. Okay, some mechanical, because ventilation, mechanical, some ventilator to mechanically force the air in. Okay, and that's what happens with that because they don't make the surfactant that holds things open. Okay, when we talk about that alveolar-capillary membrane, again, it's so thin. It's about half of a micrometer thick. So it's not just thin. It's super thin. It's basically a squamous epithelium with a little basement membrane and stuff like that. And around that membrane are capillaries. Okay, and it's like a web of capillaries that are all around that alveolus that's surrounded. So you have the air sac, and around that sac are all these capillaries. And that's because what happens is if I want that oxygen to go from the inside of the alveolus through the wall, very super thin, through the wall of the alveolus, through and into the wall of the capillary to get in the capillary to be able to load blood with oxygen, which is going to be carried. Most of the oxygen, about 95% of it, if not more, is going to be carried by hemoglobin, okay, which is a certain protein in the blood, okay. So we have a very thin capillary basement membrane, squamous epithelium and stuff like that. They have a couple, and I wouldn't worry about this, they have a couple different type cells. One's type 1 alveolar cell, which is squamous epithelium. Type 2 are cuboidal, and they make the surfactant. Those are the ones I talked about that make the surfactant. They're a little bit different cells, okay, and again, those are the ones that don't actually start working until closer to the time of actually delivery time, okay, not to Papa John's or something like that, but delivery of the baby. Okay, so that's what that. And then we also have, like I talked about, alveolar macrophages. These are called dust cells. And what happens? Those are the white blood cells that are inside the alveoli. They will gobble up all the garbage that gets down there. So in other words, if I get if I get all those little dust mites, or if I get bacteria that get down there, I don't want them to sit there and start to grow and create an infection. So what happens is these alveolar macrophages, or white blood cells, dust cells, will go in and clean them up. They gobble them up and eat them and destroy them. And then they take them in. We talked about that, how they wrap around them. They phagocytize them, they wrap around them, pull them inside, and then what happens is that material binds to the lysosomes inside a cell. Remember, lysosomes have the enzymes. The enzymes then destroy or eat that up or dissolve it, and then they, by exocytosis, they eliminate it from the cell to be gotten rid of, and it's inert at that point. Okay, and again, this is just looking at the inside of an alveolus, where what happens is you can see there's the inside of the alveolus. Inside the alveolus in here, and then here's the capillaries around the outside. They're going to be picking up all the blood, all the oxygen that's going to be able to get through the wall of the alveolus to be able for gas exchange. Okay. Then going back to where we were a week ago, that deoxygenated blood that's in the heart, that's returned to the right side of the heart from the body. The oxygen has been taken out, which means deoxygenated. D means down from, descending from. The oxygen has been taken out and replaced with what? Carbon dioxide, a waste product. So that deoxygenated blood that is delivered to the lungs by the pulmonary arteries, as we know, comes back to the right side of the heart, pulmonary, and then it goes out the right ventricle, out the pulmonary arteries to the right lung and the left lung. Okay, and as a result, what happens is the carbon dioxide is eliminated in the lungs through the alveolar wall, put out, goes through the capillary wall, through the alveolus, gets inside the alveolus, and then it could be exhaled. At the same time, the oxygen that's been breathed in could go into the alveolus, now goes across that alveolar membrane, across the capillary membrane, and gets in the capillary, so it's now going to be able to go and be delivered. At that point now, the blood becomes oxygenated. Okay, and oxygenated blood then goes back to where? Goes back to the left side of the heart, and the left side of the heart then actually sends the blood out to the rest of the body. I'm going to bring this up because I'd be willing to bet you that I'd be willing to bet you that if you ask somebody in most of the other A and P classes, how do the cells of the lung get their blood supply to live? And they'll say, oh, because they have the capillaries around the alveolus. And you can say, no, stupid, that's not the way it happens. The lung actually gets its own blood supply by what we call bronchial arteries. Okay, the bronchial arteries are arteries that are actually come off the either off the aorta or off the subclavian or the brachial cephalic. There's a number of different ways they come off. And basically, we have special arteries coming from the left side of the heart. Why? Because that's the oxygenated blood on the left side of the heart that's leaving the left side of the heart. So therefore, I have blood vessels that go from the left side of the heart that will actually go to the lung to supply the lung with oxygen for the cells to live. The oxygen that they get in the air does not provide them, the cells, with the oxygen they need to make energy. The blood vessels and the capillaries that surround the alveoli, they do not provide the oxygen for the cells in the lungs to make energy. The cells in the lung, to make energy, get a blood supply from the bronchial arteries, which are off the systemic circulation. Remember that. That's important. Okay. So basically, that's what we talked about before. Now, again, like I mentioned before, the alveoli are coated internally with that surfactant, and the surfactant creates a surface tension that keeps the alveoli open. It's critical. Okay, it prevents the alveoli from collapsing and shutting down. And again, the problem, like I mentioned before, in a newborn or immature lungs, there may be a problem with that. Okay, and again, that alveolar site is the site of diffusion of gases during respiration. Carbon dioxide and oxygen, both of them. They go across that alveolar wall into the alveolar capillaries, which surround the alveolar wall. Okay, and that's the respiratory system anatomically in a nutshell. Okay, so what did we talk about today? We talked about another thing. We talked about the purpose of the respiratory system. What else did we talk about? We talked about the fact that the anatomical structures, the importance of the nose, the importance of the mouth, the nasopharynx, the oropharynx, the laryngopharynx, the trachea, how the lungs are divided into lobes, and the bronchi have a bronchus or primary bronchus go to the right lung, primary bronchus to the left lung, and each lobe gets a secondary bronchus. And then as I get deeper in the lung to what are called bronchopulmonary segments, I get tertiary bronchi that's smaller, and then smaller and smaller and smaller, and those bronchi are pretty stable. They're pretty open because they have cartilage around them. But when I get down to the bronchioles, they'll lose the cartilage and they have muscle. So the muscle allows the bronchioles to change in size to divert air. Typically, just sort of another fun fact, okay, we're filled with fun facts in Bio 1221, is the upper lobes of the lung usually aerate better than the lower lungs. Can you think why? Simple. Air rises. So the air rises, and therefore the upper portions of the lungs, and this is also a fun fact, well, I don't know if it's fun, but if people with TB, when they have TB, the most logical and most common place to start to see lesions or changes in the lungs are in the upper lobes, because that's the air that gets aerated better, filled with air a lot more. So hopefully this gave you a good run through in regards to a little bit about the function of the respiratory system, as well as the anatomy of the physiology a little bit of the physiology. We'll talk more about physiology in our next PowerPoint video, but it tells you a little bit about what's going on in the respiratory system and how well it works together with the cardiovascular system. Again, if you have any questions, I'm always open to answers, to getting any answers for you, and I'll be happy to talk about it. Thanks. Tune in again real soon.